Okay, so basically what we were talking about is the idea of the structure of T3, T4. It is lipophilic, but it breaks the lipophilic rule of not having the charge. That's the problem here. That's why it's so confusing, because it's a lipophilic that's charged. So it's kind of like it doesn't make sense, because the good function that we have of lipophilic is that its molecular structure is similar to that of the phospholipid membrane. So it's able to have permeability. It's able to go inside the internal surface. Now, so thyroid has a difference here. It is charged. So because it's charged, it actually uses a transporter which allows T3, T4 to go inside the cell. Now, the list that we had, remember the PET, the CAT? Let me get you that list and put it on the screen. These intracellular types of receptors, remember all this. It's right here. Progesterone, estrogen, testosterone, vitamin D, cortisol, all of these, and aldosterone as well, are derivatives of cholesterol. What we see here with T3, T4 is a lot different. You'll see how it's made. Exactly. We'll talk about how the amino acid tyrosine basically ends up making your T3, T4 in a process. We'll talk about that. But T3, T4, again, is the exception when it comes to its receptor. Why? Because the receptor is not in the cytoplasm. It's actually in the nucleus. So it has action that allows it to go inside the nucleus. So T3, T4 is able to express transcription factors that will code for, that would upregulate. This is important. It's going to upregulate ATP channel. So sodium potassium ATPase has upregulation. Now you're probably saying, hey, but isn't that super vague because there's so many different types of sodium potassium ATPase inside the cell? Doesn't that just increase the amount of depolarization that the cell will have a stronger depolarization? Yes. So you'll see more metabolic activity that happens with an increase in T3, T4. Thyroid hormones basically will increase your basal metabolic rate. Does that make sense, everybody? Hopefully that makes sense. So far, so good. Yes. Yes, yes. Good, good, good. You're still with me. Good, good, good. Yeah, I'll repeat. So T3, T4 has this, first off, it has the permeability. It lacks permeability into the phospholipid membrane like the other types of cholesterol-derived hormones, which enter straight up. They have permeability. They enter inside the cell. This one needs a transporter. T3, T4 needs a transporter, although it still is lipophilic. I know it sounds super weird, but just because of the fact that it has a charge, it needs a transporter. When it goes inside, instead of it having a receptor, remember you have receptors in chaperone at the level of the cytoplasm. Instead of having this, you have your receptor inside the nucleus. So T3, T4 is able to go inside the nucleus, and it's able to express basically these transcription factors that will promote the transcription, the release of mRNA, to code for proteins that will upregulate sodium potassium ATPase. So you're going to end up making more and more sodium potassium ATPase on all these types of cells, basically. And when this happens, your cells are now functioning at a higher level. Your cells are now depolarizing more efficiently, let's say, at a higher rate. That's why they say that it increases your basal metabolic rate, right? And we'll see the manifestation of this when it turns pathological and you have way too much increase. You'll see how it's going to express itself. But yes, this is basically what happens. So all the cells are now functioning with an upregulated system of sodium potassium ATPase. They're functioning a lot more, all right? Does that make sense? Good, good, good. Perfect, perfect. Everyone's still with me. Good, good, good. All right. So thyroid is very important. So if I'm telling you this, if I'm telling you about all this activity that it can do at a systemic level, super important. So of course, we have our thyroid gland. Let's show you how it looks. Let's give you a little image so we can understand where it's located and everything. Right around here. let's say it's like a butterfly region you're going to see, and it's going to be able, yeah, found this area right here, thyroid. Thyroid is made up of these cells called follicular cells, which are very important. You remember thyroid also, instead of just releasing T3, T4, it's also responsible for releasing another type of hormone. We talked about this yesterday. Who can recall? What was that hormone? Does anybody remember? Calcitonin. Yes, that is true. Remember, it also has a response. A lot of people forget that it has a responsibility when it comes to decreasing the amount of calcium. It also can regulate your calcium. A lot of people forget that. We just tend to think that it's involved in the process of T3, T4. But okay, so yes, let me also allow you to see the feedback system. Remember, we were talking about feedback system before. We mentioned the idea of TRH on the hypothalamus. We mentioned TSH from the anterior, and then we mentioned the creation of T3, T4. So, okay. With this being said, something that we should emphasize on is the second messenger system. I know I keep going over it, but it's super important in this sense because here we're seeing a difference in second messenger system. And this is very interesting if you think about it, because TRH functions with GQ, second messenger system. And if you don't know the second messenger system, you're taking step one, make sure you do know it because it's really high yield. So GQ, while TSH will function GS. And we just said right now, T3, T4 is intranuclear. So they each have different expression, well, different second messenger function, each of them. Does that make sense? So not to let's say to be too abundant, but I'll tell you that the GQ, the whole idea was the whole phospholipase C, remember, PIP2, you guys remember that? Basically DAG, and then you're going to have your PIP2 becoming IP3. You remember that leads to calcium. That's what will allow you. That's the second messenger system. Let's not go over it too much, but remember GS was the adenylate cyclase, the ATP turning into cyclic AMP increase. Guys, remember that? Protein kinase A activating the phosphorylation of certain proteins, which will induce transcription. And transcription will lead to the release of TSH. Then, of course, when you have TSH, you're going to have activation, creation of T3, T4. So they all differ. That's the one thing, right? We have that down. Everybody understands that? Let's go step by step. Really, it turns really simple in the beginning. As we keep going, it's going to get a bit more complicated, right? A bit more complicated. So, okay. So let's understand the synthesis of T3, T4. This is happening at the follicular cells. So yes, we do need to understand exactly what's going on. So before we even jump into this whole idea, let's understand the elements. What basically do we need to make these thyroid hormones? What do we need? We're going to have an abundance of iodine. Yes. Good. Perfect. Yeah, it is essential. We take it from our diet, right? Here in the Western world, they put it on salt, which is awesome. And it becomes, in order to become usable, though, it has to become iodide. And okay, so iodide, let's say, iodide going to be the unusable version, but when it goes into our blood, we're able to operate with it as iodine. And iodine is just simply the oxidized version of this. So in order to make it biologically active, you have to basically oxidize it. Okay. Now, let's be a bit more specific. We're going to see something very important. This enzyme, there's an enzyme called thyroid peroxidase. Thyroid peroxidase, a super important type of enzyme. I'm going to write it here. Thyroid peroxidase. It's going to do three major functions, three major things. It's going to do oxidation, going to allow oxidation of that iodide, right? Oxidation. It's also going to ask for, it's also going to do organification. Organification and coupling. Coupling. Hopefully I'm spelling it right. Doesn't matter, but this right here. You remember, this is the three steps of what it's going to do. It's super important, this enzyme. And definitely. So far we mentioned iodine. We mentioned the idea of thyroid peroxidase. So far, so good. Now we have to mention two other things that are very important, two other elements of this that's very important before we even get into it. There's something called thyroglobulin. Okay, do not confuse this with thyroid binding globulin. Those are two different things. All right. First off, one thing that's very different from it is that this is made from the actual thyroid follicular cells. They are going to make the thyroglobulin. This is the acronym TG. So this is made by follicular cells. Okay. The idea of thyroglobulin, just imagine a protein which is going to work. Its basic function will be like a holding protein. It's going to allow the creation of T3, T4, and all this in order to get organified, in order to become units of MIT and DIT. We'll get into that. But you need something to hold it together while you're creating it. That's just the job that thyroglobulin will do. And when it serves this job, it gets recycled. Do it over and over again. So we'll talk about that. We're just mentioning the players now. Last but not least, I should also mention the thyroid binding globulin. Now, remember, when we're talking about anabolic steroids, if you were with me for that class, talking about anabolic steroids, we mentioned that the liver is very smart. The liver can create carrier types of proteins. Remember, the liver, of course, is creating proteins all the time. And it's able to create a protein that will attach or grab, let's say, it will saturate the hormone that it doesn't want. Let's say it doesn't want a hormone to be active, biologically active. It's able to carry it, to grab it. That way, that hormone cannot actually have any kind of reaction in our body. So we saw the example that I gave last time was a sex binding hormone globulin. I said that if you increase your testosterone, you will then release more SBHG in order to grab that extra testosterone. So our liver does the same thing, same idea with thyroid binding globulin. It's able, it makes a whole bunch of this in order to grab up any type of free T3, T4 that's in the circulation. It just leaves a small amount, very, very small amount as free T3, T4, as free T3, T4. Does that make sense? And this is a big like modulation type of strategy for our body, because if we run out of T3, T4, well, thyroid binding globulin can dissociate itself from the T3, T4 that it's grabbing. Does that make sense? Does that make sense? So we're going to see we have a big system when it comes to the modulation of T3, T4. This is just one that I'm mentioning right now. Thyroid binding globulin made by the liver. And what does it do? It grabs T3, T4, making them not free, taking away their free status. Now they're not free anymore. Okay? Does that make sense? Hopefully it does. And also, good. Makes sense. So yeah, we'll see how far we can get today. We get super far, we can do some type of arrow situations like we did yesterday and try to understand everything. And it should make sense in that realm. So, okay, TBG. So let me just now, I think now is a good time for me to mention TBG. What ends up happening with the liver, and I mentioned this before as well. We always compare the liver with the kidneys a lot of time. One thing I'm going to tell you about the liver is that it is very non-specific in its action. What do I mean? If you rev up the functionality of the liver, if you, let's say, are taking OCPs and you're breaking down a large amount of hormone, you're making that liver work very hard. It's going to work hard in every aspect. This is one way I remember the liver physiology, how it differs from the other type of organs. If the liver, basically, let's say it can put out cholesterol, let's say. If the liver is functioning super hard, it's working extra hard, it's going to be able to put out a higher level of lipids, for example. It's one thing it can do. You're taking OCPs, you're making the liver work really hard. So all the function that it has will increase. It's very non-specific. Unlike the kidneys, that's very specific, right? Remember we talked about the channels yesterday, how it could increase an electrolyte or decrease an electrolyte based on the demands of the body. Liver tends to be very stubborn. If it wants to increase the function, you can see that with the P450 enzyme, for example. That group of enzyme would either all increase or, let's say, the activity of it can all decrease depending on what type of drug you're giving. So I'm simply saying that if you rev up the liver function, many times it will produce a lot more proteins, right? Think about nephrotic syndrome. When a patient has nephrotic syndrome, you look at the cast, they have these fatty cast. It's like, okay, well, what's going on here? The liver is working extra hard, trying to provide as much protein as it can, and much albumin to the body. Well, it also starts to have release of lipids as well in that situation. So in this case, let's say the patient is taking OCPs, or let's say the patient is pregnancy. You're going to metabolize a lot more, let's say, hormones. If that's the case, then you're going to make a lot more thyroid binding globulin. You're going to make a lot more of thyroid binding globulin. Does that make sense, everyone? Does that make sense? If you make a lot more thyroid binding globulin, then the free T3, T4 that you had before will now be captured. You'll bind it. So if you have a rise in TBG, either OCPs or your patient has gotten pregnant, and what ends up happening is that you're going to have more, let's say, bound T4, let's say. Why do I say T4? Well, T4 is more abundant, although T3 is more biologically active, stronger. It's a lot stronger. So T4, more bound T4. If you have too much T4 that's bounded, the body just reads the free, not reading what's in the grasp of TBG. So what ends up happening is that your body will now read that it has less level of T4. And remember, this will give negative feedback. If you have a less T4, well, then guess what? You're going to stimulate the pathway. You're going to eventually stimulate the hypothalamic pituitary thyroid axis. If you have decrease in T4, that will lead to release of TRH. TRH will stimulate TSH. So in essence, you will start to release more T4. So now you start to synthesize more T4, increase synthesis. Okay. So the T4 that's being released is binding the extra TBG. It's binding the extra TBG that's getting made. And it does this until it overwhelms the TBG that's getting made. So then you'll have now an increase in overall T4, of course, because the T4 that you were making was getting bounded by TBG until it basically overwhelmed. It was able to occupy all the circulation, all the TBGs that were in circulation. And then the free T4 now went back to normal. And then what happens is that the demand of normal, let's say, I'm going to put here, the demand of when you have normal T4, you shut off the negative feedback. Does that make sense? If that did not make sense, I'll explain it again. That is super high yield here for step 1, 2, 3. It's the whole idea of how your liver creates more TBG in under these conditions of pregnancies or OCPs. Good. I'm glad that made sense because it can get confusing. So overall, if I say total T4, will that be higher or lower in pregnancy? So, well, the free T4, when I said it increased, I was talking about it coming back to normal. When I say that, when I drew that the total, let's say the total T4 does increase. Yes, but the free goes back to normal. Yeah. I probably wrote it the wrong way, but this is how it is. Free goes back to normal. The total T4 does increase in that sense. All right. So that's one scenario. And it is a high yield scenario. A lot of people know that scenario, but there's also something that can decrease TBG. A decrease in TBG. Decrease in TBG could actually happen with steroid usage. So if somebody is utilizing steroids, or somebody, let's say, has somebody's utilizing steroids, or somebody has Cushing's, let's say. Notice that Cushing does have hypertension. What could happen? You can have a decrease. Steroid use can decrease this. Can decrease it. But it has to be a lot. It has to be a lot of steroids. Yes, I'm talking about cortisol or exogenous usage of dexamethasone or anything like that in that sense. Why does it do this? This should be the question, right? Why is this happening? Why is steroids being able to do this? Well, remember that steroids causes proteolysis. Proteolysis. It starts to break down proteins. That's not discriminating. It's not saying, oh, I don't want to break this one down. It's breaking down these carrier types of proteins as well when it's in an excess, when you're giving way too much. Eventually, that proteolysis catches up and it starts to break down your TBG. Okay? So keep that in mind. So, okay, we got TBG out of the way. Does that make sense, everybody? Does that make sense? So far, so good. So far, we're rolling smoothly. Time flies so fast. I feel like we just started. We're already half an hour in. But okay. Basically, all I have mentioned was that these elements. Basically, when we were mentioning these type of elements, we just mentioned the key players of it all. We said thyroid peroxidase. We said iodine. We also mentioned TG, and we mentioned TBG. So, okay. Now let's see what happens exactly. So I'm just going to show you guys the image. I think it's best you guys can just see the image, and we can go and dictate what goes on here. Okay, so if we are looking at, all right, so this is what we're talking about. Here in the blood, right, you're going to take up your iodine. Iodine needs to be taken up. It goes in with sodium. Now, this is very important because this is what basically is going to make up your T3, T4. Before anything, remember that tyrosine, basically T4, T3. Remember what amino acid is that a precursor of? What amino acid helps make tyrosine? Who remembers? What's the amino acid involved? Okay, phenylalanine is a valid answer, right? Because phenylalanine, basically, at the level of the liver, in the liver, phenylalanine can convert itself into tyrosine. It happens in the liver, and it utilizes tetrahydropterine phenyltetrahydroterine. This is a reaction that we can see. Remember, if we lack this process of phenylalanine, I believe it was a hydroxylase or this cofactor function, we can have what disease? Who remembers? PKU, correct. Good. PKU, yes, definitely. And remember, it's malignant PKU if it's the cofactor, and it's PKU if it's just the enzyme, the phenylalanine hydroxylase. All right, but that's a whole other class in biochem. But the point is that tyrosine basically will convert itself, yes, to thyroxine. Super important in that sense. But the tyrosine also builds up many residues on TG. It's also responsible for the residues that are built up on TG. You can find it like this as well. So it has those two functions. But okay, point is that what we have going on here is that the first step is going to be the entrance of iodine. It has to go inside first, right? It has to make its entry. It's pretty thick. Goes in with sodium, Sim-Porter type of channel. And then iodide itself, you'll see, will undergo the process of organification. Now, we said that the enzyme here responsible was, you guys can remember, what enzyme is responsible for this? Thyroid peroxidase, correct. TPO, yes. Oxidation happens. The iodide moves towards the apical side of the cell, where it then enters the follicular lumen. And that's where you have an enzyme, thyroid peroxidase, that will oxidize it into its active form. Now it has become active. So at the level of the follicular lumen, the iodide will encounter TG. We already mentioned the idea of TG. We said that TG basically is going to be something that starts to build up. So let's see, let's put it like this. Hold on. Let's put it like this. Let's be super accurate here. Let me draw it like this because this happens more towards the middle of the follicular cells. So iodine enters, becomes iodide. And then, of course, this happens because of TPO. And then the next process is the process of organification. Organification, you're taking this iodide and you're adding them on to TG, your TG. So TG is like a plate, basically, being able to hold all these things together. That's the organification function. So it could enter either one iodine or two iodines. It could enter one or two. So let's say if it grabs one, we're going to call that MIT, right? Because I'll tell you what happens. In this sense, you could only produce two different types. One called monoiodothyroxine or diiodothyroxine. So MIT or DIT. So here, this process of organification, let's say, where you're grabbing these and putting them together onto the TG, you're going to either grab one MIT, one DIT, or you end up grabbing two DITs. And if that's the case, grab two DITs, you'll have T4. If you have one MIT and one DIT, you'll have a potential T3. And this organification process is going on because of thyroid peroxidase. Okay, good. That's organification. So basically, these molecules, a lot of them are being stored within the thyroid gland, and that's super important. That is super important. I'll tell you why. Because if there's an inflammatory reaction, remember we mentioned the concept of increasing the permeability of membranes whenever you have an inflammatory damage of a cell. Why? Because of the swelling that happens. There is reversible type of damage that can go on typical cells. And when swelling happens, you tend to leak certain types of enzymes that are found in the cytoplasm. That happens many different areas. Let's say in the heart, you have troponin. It's a giveaway that there's ischemia going on in the heart. If there's liver enzymes that are leaking, AST, ALT, that's evidence of the liver getting damaged because there's a higher level of permeability when there's swelling of these cells. So if it works as markers for us, whenever you have swelling, you're able to see a release of certain types of proteins in the muscle. And part of this concept also entails that some of these markers are permanent markers, and some of these markers are reversible markers. In the muscle, you have CK, the creatine kinase. And the CK, if it's increased, it basically is letting us know that there's a myositis going on. Now, if you have myoglobin getting released, that means that the damage is a lot stronger. It's more of like some kind of irreversible type of damage going on. It's something like myoglobin. That's why they give this a complete different name. If it's CK, large amount of CK, inflammation of the muscle, myositis. If it's myoglobin being released at a higher level, you're going to see this being called rhabdomyolysis. Now, which one is worse? Rhabdo, of course. Rhabdo is more of that irreversible type of damage. Like it's some real serious type of damage of the muscle. While myositis is like the reversible type of damage. Nevertheless, both of them are types of damage. These are markers I can show. The reason I'm telling you this is because you will see that whenever there is an inflammatory type of reaction, it should point towards whenever there's an inflammation of the thyroid, it's going to first demonstrate a level of hyperthyroidism at first. So at first, the storage that you have of your T3, T4 on the follicular cells start to leak. That's why when we talk about different diseases, we'll see that there's going to be higher levels of T3, T4. In the beginning, there's this weird thing that happens. You can see this in Hashimoto thyroiditis as well. There's phases, yeah, definitely. You'll see someone tell you that the chronic lymphocytic thyroiditis, also known as Hashimoto's, there's a moment where there can be some kind of increase in T3, T4. And we'll talk about all that when we get into the pathological sense of it all. But yeah, it's super important to understand this. Inflammation can cause this. Now, there's a difference. There's pain, and then there's there's the type of situation where you don't have pain, right? That's one thing that can work. Now, typically, I'm going to tell you the rule, and this is the rule that's going to help you here. If it's painless, I should think that it's caused by autoimmune disease, or medications, right? And if it's painful, it should be caused by things like infections, should be caused by things like radiation, definitely. The most common cause of thyroid pain is dequervates, definitely. Infection, radiation, what else? Trauma as well. So if it's painful, we're thinking this. If it's painless, it's usually autoimmune and medication. Postpartum. If patient has postpartum, there is going to be thyroid gland enlargement. Yes, it is non-tender. It's painless. Yes, it is. It's called the type of silent thyroiditis. It is also painless. Yes, definitely. So it's characterized by that thyroid toxicosis followed by hypothyroidism. So you do have the hypothyroidism afterwards. It's the whole idea of leaking of the T3, T4. I mean, that makes sense, right? You'll see that Yeah, when we do questions on this, we're going to have a question session, I believe, tomorrow. We'll have a question session where we'll talk about differences of all of this. And today we should get to the management as well. So, all right. Yeah, just while we're mentioning it, I'm telling you why these kind of things happen. Thyroid just happens to be one of those type of organs that leaks out um, active, bioactive form of hormones. Typically, you don't see that. Typically, there's just enzymes that don't have too much action outside of the cell, like CK or myoglobin. Well, myoglobin is very toxic to the kidneys, right? Yeah, we'll talk about all those different causes. But yeah, so far we just mentioned the generation of how you make your T3, T4. And yes, it's more abundant. Um, yeah, you have a whole bunch of T3, T4 that's being stored. That's the issue there. Now, they get stored until they're ready to be released. When you release these type of T3, T4, they have to be released from the TG. TG that can't just hold them and go outside. TG likes to stay in the inside. TG will get recycled and used over and over again. So let's see this in function. Let's see how this actually works. You're seeing that you have endocytosis of the TG, and this here reacts with some proteases that are found here in the follicular epithelial cell. These proteases will basically dissociate the T3, T4 that's found on the TG. When that happens, it now goes into circulation. So a very important type of enzyme we need to understand here is that 5-deiodinase. This will break down your T4 into T3. That is very important, right? This happens at the peripheral level, but a lot of books don't really emphasize on another type of bioconversion that goes on at the peripheral level. We have T4 becoming T3. That we do understand, right? That makes sense. But there's also going to be a conversion where you have a isomer. So T3 becomes an isomer version, something called R. Make it lowercase because it is an R T3. So you remember what an isomer is? The same molecular structure is just rearranged differently. So you have some kind of bond in, let's say, two specific areas. They're going to switch it around. Same bond will still be attached. It's just the location of it switches. That's it. It's isomer. It switches in a mirror form, right? So yeah, this becomes an isomer. This happens. The way that it happens, you're going to see that um, basically they have happens at the peripheral level. It happens with this is first off, the reason this happens, why does it happen in the first place, is a form of modulation. Remember, we mentioned that you have to control these types of levels. This here is inactively, is biologically inactive. Biologically, well, I'm going to spell this wrong, but inactive. It is biologically inactive, but that doesn't stop it from binding the same places that T3 binds. That's the important feature here that I'm telling you. It can modulate the action of the T3 because they both compete for the same receptors. They both enter and do the same exact thing, but this is an inactive form. All right, so it prevents the body from responding too much to T3. Hopefully that makes sense. Okay, that's one thing that does happen. So it's another form of modulation here. So far, we mentioned the form of modulation. It's important to know the forms of modulation just because this is what gets altered in different types of diseases. So TBG we mentioned, and now we're mentioning RT3. All right. And just to let you know, the rate of T4 becoming T3, about 10% of T4 each day turns into T3. That's what happens at that level. Right? Remember that T3 is stronger in that sense. Okay. Any questions so far? Any questions so far? Form of modulations, we've mentioned increase in iodide as well through the Wolf uh, Chakoff effect. That's another way of modulating. Wolf Chaikoff. I wonder what kind of country that name comes from. It sounds maybe German. Not sure. Yeah, sure. So at the periphery level, we have different conversions that happen. There is a conversion that can happen from T3 to T4 that it can become biologically inactive. But the problem with this is that they still try to bind to the same receptors, to the same areas, to the same spot. So not only is this inactive form of T3 decreasing the action of T4, I'm sorry, not only is this inactive form of T3 causing a decrease of the activity of the active form of T3, it's also, um, basically it's competing for the same spot, same receptors in that sense. So if T3 is doing too much action, it's just becoming too strong, we have too much of a thyroid effect in the body can use this form of modulation to calm your T3 down, to say, hey, T3, you're being way too active. Make sure you don't overactivate this patient. Reverse T3 will compete for the same type of receptor. Does that make sense? Now, why am I mentioning this? Why is this so important? Well, there's something called uh, euthyroid, euthyroid sick syndrome, right? So what ends up happening is that these patients, well, first off, they're chronically ill patients. These are patients that have um, a lot of issues, other type of comorbidities. They are typically in hospitals and ICUs and these kind of issues. Um, they are critically ill patients, first of all. So it makes the diagnosis easier if you can know your demographic. Um, with these patients, when you try to manage them, there's no treatment required, really. It's something that should get better. But what you'll see is that they'll have evidence of a low T3. And the low T3, it could happen when you have a lower rate of conversion, T3 going into T4 going into T3. I told you that a healthy rate of conversion is about 10% per day. If the conversion rate is lower, like it is in chronically ill patients, you can have this disease called euthyroid sick syndrome. So the thyroid is functioning with its normal capacity, but the problem is at the peripheral level, you're not able to convert your T4 into T3 properly. There's many reasons why this can happen. It can be steroids, or patients have high levels of cortisol, cytokines, many different issues that can not allow that enzyme, the 5 prime iodinase enzyme, to function here. So patients should have a low T3. That should make sense. But the TSH can be low to normal, right? As this gets worse, it's in a spectrum because it can get worse. So in the beginning, TSH, I expect it to be normal. And in some situations, it could be low. As this progresses, let's say, you'll see that the TSH is now, I expect it to be at a lower level and not normal. So you can definitely do a thyroid panel and check different types of hormones in order to understand at what stage or how bad this is, right? As it gets worse, you'll see that your TSH levels will start to drop. So there's no treatment required. It should get better as the patient is getting better himself. So definitely, what do? We have to check the thyroid panel, and you should see this. So just to tell you the labs, we should end up seeing a patient who's chronically ill, first of all, and having low, if it has gotten really bad, TSH, lower T4, and low T3. And how can I know that this is the problem? Why is it not just a thyroid insufficiency or some kind of issue in the thyroid? Well, I would have to check the R T3. Check this. Check that. Because if that is high, then you have your diagnosis. This will equal euthyroid 6 syndrome. Right? Makes sense. Does everybody understand that? Does that make sense for everybody? Okay. All right. So the issue is that, yeah, the issue is that you're not having, let's say, all right, when you have that RT3, it does tend to bind to the same receptors that T3 will bind and inactivate whatever action was going to happen. So remember that the thyroid is also sensing your levels of T3. Let's say, let's say the hypothalamus and the pituitary is sensing your levels of T3 and T4. It's able to sense those levels. That's the sensing type of tissue. You're able to block those as well when you have a higher level of RT3. Does that make sense? As it gets worse, you produce more RT3, and they start to uh, bind the hypothalamic and the pituitary type of receptors that should be welcoming T3, but it's also welcoming RT3. Remember, yeah, good. That's like the whole idea of androgen insensitivity syndrome. Remember how their level of TSH is uh, their level of testosterone is super high, and the hypothalamus can't really read that you have a high testosterone. You see what I'm trying to say? So here, the reading, the sensing type of tissue is also kind of skewed here because of that, right? So hopefully that makes sense. Now, if your RT3 is normal, or your R T3 is not high, then you should think of another disease, right? You should start to think of a differential diagnosis there. But that's the whole idea behind that. That is how that will typically work. Okay, good, good, good. Another thing that we should also take a look at is the values. Let's look at the values. I should put this in the screen in the very beginning because we need to understand the values that are shown. So this is the values that you should expect when you look at TSH. Total T4, total T3, and then the free T4. That's how you check your, they call it a thyroid panel in order to know if a patient is normal or not. But many times when you're looking at the clinical of a patient, the question itself would help you so much because they paint these pictures. They're very clear. Increase in, they say that the patient's diet has not changed, yet the patient has either gained weight or lost weight. Definitely lets you know if it's a hypo or hyperthyroidism in that sense. A lot of thing that goes on though with the hyper or hypo. So let's understand. Let's understand everything. Let's go now to their clinical. So now we understand. We understand how they're made. We understand the peripheral conversion. I should also mention that there are certain types of drugs that could inhibit the peripheral conversion. So T4, T3. So P for peripheral conversion. Let's look at some little fun mnemonics just so we can remember things. P for peripheral conversion. So PTU does the peripheral, inhibits the peripheral conversion. Remember, methimazole and PTU both inhibit tyrosine peroxidase, except PTU also inhibits 5 prime I iduronate, I think it is. I don't remember how to spell the word correctly, but yeah, PTU. Also remember propanolol. Propanolol as well, another P. Also, I'm going to ask you guys an important question. During the first trimester of pregnancy, if you're given the option to give PTU or to give methimazole, what do you give the patient? PTU, right? PTU. Pregnancy as well, PTU. P again. You see that? Everybody sees how the P basically tells you everything there? Hopefully that makes sense to everybody. Then methimazole, yes. Then methimazole. Good, good, good. That's good. Everything making sense so far. We're flowing correctly. That's great. When it comes to the peripheral conversion, we understand. PTU, propanolol, peripheral. Good. All right. And these are the values that we need to know. So if a patient, let's say, there's also clinical features that are going to happen on both, and we'll talk about both. So if a patient, for example, is having hyperthyroidism, this is so easy. Like, what do you guys expect to see in their labs or in their clinical findings? Of course, of course, there's so many different things. Increasing cardiac output, right? Because they're going to have, okay, so before, yeah, high T3, T4, basically, right? Typically, there can be scenarios where they don't have low TSH, but I see what you mean. I see what you mean. Um, but there's certain things that make us suspicious. So, um, if we see sweating, palpitations, weight loss, we see fatigue, we see that the patient there's very like those are more non-specific type of symptoms, and then there's one that's just straight up pathognomonic in that sense. There's just one that sticks in perfectly, which is that tremors can be seen. Yes, tremors. What's the most specific one? Where if I see this, weight loss can be seen, but again, that's weight loss can be seen in cancer and different things. But there's one feature. There's one feature that if I see this, I know for a fact the patient might have Graves, actually. I know for a fact he might have Graves. Pretibial edema. Okay? Seen in Graves' disease. Pretibial mixed edema. Mixed edema. Yeah. Yes. This one right here. Yeah, sorry to spell this right. Definitely. This one is key to Graves. But yeah, let's not jump all over the place. Let's understand. Let's be very organized. Don't want to jump all over the place. Although I am getting excited thinking about hyper and hypo and all the different type of features. But it is fairly easy to differentiate the two. And with thyroid, there can be if the thyroid can affect development. That's one thing that is important, though, when we're talking about let's say maturity or development of kids. There's a lot of brain function and bone function that is dependent on this thyroid system, right? That makes sense. So if the patient does not have proper thyroid levels, it can have cretinism, which in reality, in real, let's say, clinical world, it's very, very, very rare to see that. But nevertheless, that is true. So, okay, one thing that we can look at is that in that sense, remember that childhood hypothyroidism leads to cretinism, but there's something that's very important as well. A feature that you can see clinically is umbilical hernias, large tongue, large tongue. Yeah, we should do a drill one day. Short stature, yes. Why? Because thyroid itself, you'll see, has actual function with with growth hormone as well. It affects the bone. So I'll tell you how this happens. It sounds kind of crazy, but T3 has development as well with myelin sheaths, and as the kid is growing, there's a lot of development with neurological movement, um, intellectual disabilities, short stature. Good, good, yes. So T3 directly enhances the formation of growth in bones, osteoblast, and acts directly as stimulators of that growth plate. That's what it also does. It promotes cartilage formation in kids. That's what T3 can do, actually. And it also forms the neurological um, system with myelin. It basically puts down the myelin a lot faster. So it does have specific type of relationship here when it comes to growth. Remember that. So that should make sense. So if they don't have this, that's why they have all this intellectual disability. That's why they have coarse facial features. They would ossify basically if they, well, if they have a lower level of thyroid hormone, they'll have an issue with the maturation of the CNS, and they'll also have an issue with growth. Definitely, that's one thing that we see in that sense. More osteoblastic activity, yes. Less osteoclastic activity. What else can I tell you in that sense? I know it was related to growth hormone, but yeah, that's what you have with the hypo. So yeah, I'm not writing much, but we understand this. We understand the difference between hypo and hyper. In the heart, this is important at the level of the heart. So let's look at it like this. Yes, increase cardiac activity with hyper. So the increase in cardiac activity can lead to a specific type of arrhythmia that we really have to watch out for. So much so that it's part of its algorithm when we diagnose this arrhythmia. Yes, it can lead to, yes, good, good. That's good. That's great. Everybody knows this. That's awesome. AFib. Yes. When we look at basically thyroid storm, thyroid toxicosis, increase, let's just say hyperthyroidism. Let's just say hyperthyroidism. Hyperthyroidism. So just to recap, patient comes in with all these different types of symptoms of palpitation, heart racing, and all this. I'm very interested in checking out his EKG. Let's say he has a tachycardia. I want to know if this is a ventricular problem or it's a supraventricular problem. I'm going to look at the QRS. QRS is what interests me the most. I'm going to see if it's narrow or if it's wide. Remember, narrow, less than 3 boxes. Right? That's less than 120. Okay, if that's the case, once I figure out it's narrow, remember, next step, I try to check to see if he's hemodynamically stable. If he is not hemodynamically stable, let's say, I do cardioversion. I do a synchronized cardioversion. That'll be the next step in management. Okay. If he's not, was hemodynamically stable, systolic, less than 90, that is alarming to me. Hemodynamically stable, no. Synchronized cardioversion. So I check if he's hemodynamically stable, and he is. Okay, what do I do? Now I want to check his rhythm. Oh yeah, my spelling is off at this time. Been up since early, so rhythm. If the rhythm is consistent, meaning that the QRS are dropping consistently, the RR intervals are landing within equalized space, like they're landing correctly, right? If that's the case, if there is rhythm, then I should suspect that the patient might have an AVNRT or an AVRT. So I would do next step in management, parotid massage, in order to do the vagal maneuver. So I'll do vagal massage, or I can give adenosine. Vagal is a lot cheaper. And then that will give me the hidden P wave I can find. That'll get the diagnosis here. Luckily, I haven't seen any question that tries to make you differentiate between the two, which is awesome. So if the rhythm is there, I'm thinking this is the diagnosis. Now I check, and if the rhythm is off, so there's a lack of rhythm. Now I check the P wave. If I can see that the P wave changes, right? You have 3 different types of P waves on a QRS, on a EKG lead. The P wave is like either very close to the QRS, or it's the next one is very far. It keeps modifying. That's what we call it MAT, multiple atrial tachycardia. And this is associated with COPD, everyone. COPD, this is associated with. So I have to try to treat the COPD here, try to make things better. And if I check the P wave and I'm seeing that there is a P wave, yeah, this is, both of them have P waves, the one I'm going to mention now. But I see that it looks like a sawtooth type of pattern. The P wave looking very sawtooth-ish. I can say it's an A flutter. Now, if there is no P wave, there's lack of P wave. Well, I'm already irregular in my rhythm. Now I'm irregular, not having a P wave. We call that irregularly irregular, right? From where I'm from, that's irregularly irregular. Now we call that straight up AFib, right? AFib. So part of this crazy algorithm, I don't think it's too crazy. I think it's pretty nice. But part of this algorithm, one thing that we do see is that if I see that it says AFib, I'm giving the diagnosis of AFib. What am I going to do here? If it's AFib, I should think to myself, first thing I do before anything is an echo. First thing I'm going to do is an echo. Why echo? Because I am interested in knowing if there is some kind of gigantic thrombus that's forming inside the ventricles. I want to know if this is actually happening with the patient, not only for the patient's benefit, but also for my own benefit. I want to know, because if you're here running labs on a patient and he has a huge type of thrombus, just some huge thrombus in the ventricles, and you're just there running labs, let's say it's a complication of that thrombus, it's kind of the doctor's fault. I will say the patient was there and he got diagnosed with AFib. It's like it could have been a thrombus forming this entire time. So, okay, we check the imaging for that. Another thing to do in this sense, so you do your echo. Another thing to do is a thyroid panel. You have to check the TSH. Why? Because of what we're talking about today. Because this can be, and the patient should pray that it's a TSH problem, because if it is, it's going to be reversible, right? You fix the thyroid storm, you fix the thyroid problem here. Definitely, you can get the patient. AFib wouldn't really happen, right? It's happening because of the hyperthyroidism. So you check the thyroid panel. The thyroid panel should show you that there's a decrease in TSH, right? If it's Graves, the TSH will be decreased, but the TSI, the thyroid stimulating immunoglobulin, should be high. Yeah, we'll look at how to diagnose all this. That's definitely super important when it comes to thyroid issues. First, I want to be able to explain the pathophysiology, then how to diagnose them. And in our question sessions, we'll do questions straight up based on thyroid, everything we gave for endocrine, including growth hormone as well. So, okay, you have to check your TSH basically. That's going to be the most important type of things you do here. Okay. If that's the case, then if we're going to treat our AFib, so let me just finish up with AFib. If we're going to treat it, I'll simplify for you, make it super easy. Treat it RAR. RAR. Rate control first. I should be thinking about rate control first. I already saw a question for step 3. I was doing step 3 questions the other day. And it was a little tricky, but I'll tell you one thing. Rate control, first off, beta blockers, because this controls rate, right? It's a rate controlling type of drug. Also calcium channel blocker. That makes sense. Remember, the nodes get depolarized with calcium. Calcium is the ion which is responsible for depolarization of the nodes. So calcium channel blocker as well. And also digoxin. Digoxin, but it's not really used as first line. So remember that as well. That's for rate. Now, anticoagulation. They had the whole Chad-VAS score. Look at that at your free time, but all you need is one risk factor for him to qualify for anticoagulant treatment, just one. So instead of me memorizing the whole Chad-VAS, I just think, okay, if he has one feature, he technically qualifies for anticoagulation. So his age, if he's an older patient, history of any kind of, risk factors of any kind of, let's say, atherosclerotic problem, if he's a smoker, anything like that. He qualifies. And for anticoagulation, they like to give 10A inhibitors. 10A inhibitors. And then the last one is rhythm. Rhythm control. Those are the antiarrhythmic types of drugs. Remember, you have all the way from 1A all the way to 3, right? 1A, 1B, 1C. Remember all that, right? That's all cardio. So we're taking a little side step to cardio. But just remember that in ischemic tissue, if I'm reading his clinical vignette, and his clinical vignette is telling me that he has had ischemia in the past, he has had some kind of issue of MI in the past, I can't really give him 1C. 1C likes to attach. It's a type of drug that likes to attach to the tissue and doesn't really dissociate much, but it works really well. But the strong level of attachment, this strong mechanism of action leads to a phenomenon called dependency, where the body gets used to having to work at a physiological level with this drug attached to it. So when you stop using it, then you have complications. That's the dependency. That's why they like to switch them off. That's why when you see antiarrhythmics, many times a drug like amiodarone, so this does connect this back to the thyroid. Amiodarone, the class 3, does function pretty well. It's great, but it has so many different types of side effects. But amiodarone does function pretty well. What is an let's say, arrhythmic that we can give for ischemic tissue? It's going to be 1B class 1B, things like lidocaine. Remember lidocaine? It's able to work when there is ischemic type of tissue. Now, why am I saying this? Lidocaine. I don't know if you guys remember the mechanism of action of local anesthetics, how crazy it is. They enter, so they have more or less, they have no charge. They are permeable to the cells. So lidocaine will enter nice and easy, freely. The problem is that once it goes inside, it's going to pick up a charge. Then it tries to leave. And as it tries to leave, it ends up blocking that sodium potassium type of channel. So that's how it blocks it from the inside. It goes inside and it picks up a charge. So why can't we give this to ischemic tissue? I'll tell you why. Because ischemic tissue tends to have a lot more charge. Remember, ischemic tissue can depolarize a lot faster. Spasms and all that. So when lidocaine makes its way to here, it says, whoa, this is way too much charge. I'm not going in there. So it avoids ischemic tissue. think that's very interesting. So that's how lidocaine, that's why it's favored in that sense when it comes to ischemic tissue. Also, tetrodotoxin from the blower fish, those type of fish, their toxin works right here. And it comes from the outside. But it has the same function as lidocaine. It just doesn't do that whole going inside and then getting kicked out stuff. Okay. Good, good, good. Now, amiodarone. Iodorone. It has this iodorone name in it. Anybody notice that? It has an iodorone type of name in it. There are certain drugs. Yeah. Iodarone. See how it has that ioda? It's almost like it has iodine in it. Yeah. Yeah, definitely. No, my spelling is abysmal. I do admit my spelling is terrible. Um, yeah, they gave points. They took away points for spelling in this exam. I would not be doing too well, or I would just learn how to spell. But amiodarone definitely has within its molecular structure. Yeah, we forget how to write. We forget math as well. I used to actually be good in math. Well, biostats I can still work, but amiodarone can start to accumulate. It can start to enter. It can start to do these types of effects in the thyroid. Before you give amiodarone, you're supposed to check liver enzymes. You're supposed to check lungs, and you're supposed to check thyroid panel. You're supposed to check all three because it can damage all this. Right? That makes sense when it comes to amiodarone. So there's several types of drugs that can cause these kind of problems. So I'm looking for a mnemonic here that I made. It's on my Instagram. If you don't follow me on Instagram, you should, because I just all the mnemonics that I have, I keep them there so I could always go back and screenshot it and post them. So for this one, it was drugs that mess with the thyroid system. The mnemonic was salt, and I'll show you the mnemonic that I made. I make little cards in that sense. So let me see. Where is it? Yeah, so many that I have. I need to make them more obvious. Salt. I'm trying to show you guys because it has an image, and I think images really work well with the brain. Like you're able to pick up on a lot of things if you're just looking at it from an image, as opposed to me just scribbling it down in a paper. So check this out. The mnemonic here, salt. These are drugs that cause hypothyroidism. And remember when we were talking about the difference of painless and painful, we said autoimmune and medications can cause painless. Right? Hopefully that makes sense. All right. So yeah, let me put this in the chat. It doesn't cause salts. It has a lot of side effects, but of all the potassium blockers, it doesn't cause salts. So, amiodarone. Uh, Sotalol does definitely. Sotalol has dual function. It's a beta blocker that also blocks that type of issue as well. It also blocks. Yeah, it can also cause that. But yeah, we'll look more into that. We'll talk about that. We got to get back all the way back into thyroid. We took a crazy deviation here. I did not expect that, but nevertheless, it was good just to know how to diagnose AFib. Now we understand how you diagnose it, how you treat it, and we understand that part of the diagnosis itself goes with the idea of checking out for TSH, checking out your TSH just to make sure that it's not the reversible problem. Okay. That is going to be super important in that sense. All right. Good, good, good. Now, we talked about a regulatory system, the Wolf Wyckoff type of system that can decrease the creation of more T3, T4. It's a very important system. It's part of the modulation systems. We mentioned a couple of them. We said Wolf Chakoff is one of them. So if, for example, this Wolf Charkov type of reaction is not actually functioning. Let's say there's a problem with it. Let's say the iodine keeps getting taken up. It keeps getting pulled towards the follicular cells and it keeps on being used to produce more T3, T4. You're going to have something called the Jod-Basedow phenomenon. And how does this happen? When you're giving drugs, let's say, that have iodide in it. So amiodarone, when you find it, they'll tell you that it causes hypothyroidism. They'll say that. But in all reality, anything that has iodide in it, like radio contrast, for example, can cause a Jod-Basedow phenomenon. And that will actually ramp up the synthesis of T3, T4. So that can lead to a hyperthyroidism. Hopefully that makes sense to everyone. It's a failure of the Wolff-Wyckoff type of reaction. Does that make sense? Good, good, good. So yeah, basically, an excess of iodide is supposed to stop the production, but you're seeing that there could be times where an excess of iodine actually stimulates more and more. And that's when you have failure of that Wolff-Wyckoff. So Wolff-Wyckoff is more of a physiological type of thing that should function to try to help you to modulate how much is being made. But you can have an issue with that as well. All right. Good, good, good. There's so many different causes. Like if you start to think of it, um, autoimmune issues, of course, that's going to be something that's super high yield. We do need to understand the difference between Hashimoto's and Graves' disease, what can happen in that sense. Um, so if we, well, all right, I feel like I am jumping all over the place, but one thing that was important for hypo that I will mention is the cardiac problems. The cardiac problems that we mentioned when it came to the hyper was the tachycardia type of problem, arrhythmia problem. So this one, just remember that bradycardia can happen. Bradycardia, sinus bradycardia, meaning that it'll show you P wave, QRS, T wave. It looks normal but slowed. Normal in its, let's say, its morphology, but it's just slower. Like you're not getting enough beats. That's what typically will happen for a patient who has hypothyroidism in that sense. Hopefully that makes sense, right? All right. So just to contrast one more thing, we contrast heart problems. We contrast weight and systemic nervous system, the central nervous system issues. We compare and contrast both of them. I think that all makes sense for all of us. Something that I do want to contrast as well was the dermatological features, derm. We can contrast this, then I think that we can just move on. For hypothyroidism, there is going to be issues, of course, with mixed edema. Now, a lot of people can get confused. A lot of people can say, hey, what are you talking about? That's hyper. But there's going to be a certain type of problem that happens with the face. You're going to see facial swelling. Facial swelling. That happens mainly because of the deposition of something called hyaluronic acid. Starts to deposit in the thermus. And it draws a lot of water out. And then the face will start to look a lot puffier. So I'm going to show you an image here. Remember, the pretibial type of mixed edema is for Graves. But mixed edema, face, the puffiness that you're seeing here, this is typically happening in a hypothyroidism problem. Now I'm just going to tell you one more thing that's a little confusing. One more thing that's a bit confusing. Hypothyroidism, it tends to, with time, if it's chronic and you don't fix this problem, it'll start to cause the aortic valve to work a lot harder. The aortic valve is taking the hit. You'll see that you'll eventually have an issue where the patient can have hypertension. So chronic hypothyroidism will end in hypertension. Just note that. Okay. So I'm going to mention some weird facts. Let's say that you guys can ask me about. We can talk about it. Basically, if chronically the body is suboptimal, let's say you're gaining weight, chronically you're not responding with a proper basal metabolic rate, your cardiac output is functioning in a compensatory mechanism for longer periods of time. These type of complications can eventually lead to hypertension. Your body will have to force itself. This compensatory mechanism will force itself to match the cardiac output by producing hypertension. Does that make sense? So that's a weird thing, I know, because it kind of goes against everything you're thinking. Hypothyroidism, don't we have a decrease in BP? If it's chronic, it can lead to hypertension. Another weird thing, amiodarone, like I mentioned before, it has iodide, so it should cause hyper and hypo. It can cause either one, just depending on the reaction that you get, right? Because that iodide could go in and you can have failure of that Wolff-Wyckoff reaction, and it will promote a Jod-Base style reaction where you're making now more and more T3, T4. Or you can have hypothyroidism because the Wolff-Chaikoff effect actually works, because you have that escape function where you can get back to normal in a few weeks, right? So there's a lot of weird things when it comes to the thyroid, but we do need to understand everything there. And untreated chronic hypo, or just in untreated chronic hypo, definitely, because your body's mechanism of compensation is not really sustainable. It's not healthy at all. And it tends to make the patient have to work a lot harder, leading to some kind of issue with the hypertension. So, yes, that's something that you do see there. Definitely, if it's untreated. So, thyroid does have a couple of weird things, but nevertheless, it does have a lot of things that make it easy. Like those features, are very non-specific features, can get you a diagnosis. But okay, also remember, in the process of inflammation, I always like to say inflammation has two things. It has both at the same time, but one thing takes over. I remember those that were with me from the beginning when we did cardio. We talked about pericarditis. We said, hey, pericardium could be inflamed. And if it gets if there's swelling that happens, then you can have cardiac tamponade. If instead you have fibrosis, you can have constrictive pericarditis. We talked about the difference. We said, hey, in inflammatory events, you can have complications that will be featured in this way. And then I told you, hey guys, remember this feature I said, because we're going to apply it to other pathological conditions. I do have memory. It's crazy. I have good memory of all the classes that I give. And this is one of those situations where if we have an inflammatory event that's happening, let's say thyroiditis, and it's more of a fibrotic deposition that occurs there, patients can definitely have something called Rydell's thyroiditis. Rydell, it feels rock hard. It's a lot of activation of fibroblast. So a lot of collagen deposition is what's happening here. There's replacement of the tissue with collagen. That collagen is not the same histology as the regular thyroid tissue, so it should feel very hard, very smooth in that sense. So Rydell's thyroiditis, rock hard, right? And so in that sense, with a patient like this, you'll see that you'll have to basically do hormone replacement for this patient. Like there's these situations that get terrible and you have to do that. And you can also try to diagnose. How do we diagnose this? With a biopsy. We should be able to see the histological features of that. Does that make sense? We should be able to find the histological features. So So just letting you know, in this sense, with these type of patients, the hypothyroidism, cold nodule. Yes, you'll have non-functioning type of tissue here. Definitely. Definitely, it should not, it's not a cold nodule. Nodule will be, when you look at a cold nodule, we're looking at, let's say, some kind of growth, some kind of like, um, let's say, some type of tissue that whenever we give iodide, we're able to see that the iodide is getting taken up because it's like active radioactive where you can actually see the contrast. So you're seeing that it's getting taken up, but then you see that kind of this mass is not allowing any take up. So it's like, hey, I have a mass on my thyroid, but it's not because of a kind of hyperplasia. It's not because of an adenoma. It's more like a mass that's non-functional. Like, why do I have this mass that's not really doing much? It's non-functional. That's a cold nodule. For Rydell's, it's scattered. It's scattered everywhere. The damage, the fibrotic deposition is scattered all over the thyroid. So it should have less pickup, yes. Of course, it's not all functional. So if you do some kind of, let's say, radioactive activity, we try to see the take up of it, you should see that the diffuse type of scarring that it has, the fibrotic deposition, is causing problems when it comes to uptake of iodide. That way, you're not making your T3, T4 like you properly should. Does that make sense? Does that make sense? Yeah. So just letting you know, there's a strategy that we have whenever we see some kind of growth, some kind of mass in the thyroid. And the strategy behind this is that we can see if the tissue that's on the thyroid, is it actually working or not? Does this, let's say, mass, and usually this is for a thyroid nodule, this is completely different. When a patient walks in with a thyroid nodule. So yeah, I guess let's segue to that. Will make more sense. But yeah, you should know. We did talk about a lot of diseases. So in this sense, let's look at thyroid nodule. So I have an algorithm here. I'll post it on the Patreon so you guys can download this and look at it this way. But this is a simplified way to understand this. So thyroid nodule. Patient usually walks in to your office. Many thyroid nodules are actually noticed by the patient. My mnemonic here is upper respiratory tract infection. URTI has nothing to do with the thyroid nodule, but in this order, I can follow this order. This strategy is followed in this order. URTI. These are the things that I have to do to try to evaluate the patient. First, you do a clinical evaluation. Well, how long do you have this for? Look at the size of it, right? You try to see if the patient has any type of symptoms. You try to see if there's any kind of family history. All that gets taken into consideration. Then you have to do the ultrasonography, right? The ultrasonography. So this says here, ultrasound not sus. So what I ended up doing is I ended up looking for all those little buzzwords that they use to try to tell you if ultrasound is suspicious or not. Let's take a look at that. All of these buzzwords right here. These are words that will let you know if there's some kind of suspicion in an ultrasound. And you can extrapolate this to different types of tissue and different types of disorder. So if you start to see these kind of words being used, like irregular margin, microcalcifications, these words are hinting you towards a suspicious ultrasound. There can be irregularity in these type of cells. So rim calcifications, extruding tissue, extrathyroidal extensions, cervical lymphadenopathy, internal vascularity. If I start to see these words being used, I start to qualify it as a suspicious ultrasound. Okay? So let me put this one in the chat just in case. You guys can use that for any other type of cancers as well. So if the patient, let's say, so it also says here, sounds like step 3. No, I would say it's more. No, I don't think it's step 3 at all. I think this can be step 1, 2, and 3. I see if I've seen a question and they're talking to me about ultrasound was done and I found this, I'm thinking to myself, was this a good finding or a bad one? But risk factors. So what are the risk factors? See how I put risk factors in here? Well, there's also risk factors that we should know. Um, let's look at the risk factors. Risk factors will be found right here. Family history, radiation exposure, prior diagnosis of men too, age less than 30 or more than 60. Those would be risk factors. Yeah, when we do questions, we're going to do a lot of questions. We'll see how we can use this as a strategy. They'll definitely let you know the results of ultrasounds, let you know the results of, or they'll let you know risk factors. But point is that if they qualify, basically, if the risk factors are there, then we can do different types of approach. So risk factors, but ultrasound is not, let's say, suspicious. We have to check TSH. That's the T part of this. TSH is, let's say, low. Then we give iodide 1, 2, 3 scintigraphy. That's the uptake. Try to see how is it taking it. You see a cold nodule. Here you're seeing uptake all over that thyroid. There's uptake all over here, except for that little part. That's a cold nodule right there. See that, Mona? That right there is a cold nodule. That's like a growth, an adenoma, but it's non-functional. Hypofunctional type. You got to biopsy that. Got to biopsy that. Got to see what's up with that in order to try to diagnose this. Right? Could be some kind of cancer. Definitely. All right. And if we're looking at cancers, remember, we have these types of cancers, and this will go into when we do oncology. We'll go into this. I'm just telling you, this is our like the most common types of cancers that you can find in that sense. So if we're going with thyroid, let me just show you. Yeah, and I drew this picture myself right here. So you see, I don't, not that I draw bad. It's just that if I don't have the time to draw it, my quick drawings are pretty bad. But if I have the time, I can draw something pretty nice. So look at the uptake. Look at the difference of the uptake. In Graves, you have a diffuse uptake of iodide. In Graves, you have a diffuse uptake of iodide. So what is happening in Graves? The pathophysiology of this can, let's see, can anybody explain it? Do that. If anybody raise their hands, you could explain the pathophysiology of Graves.
Can I do that?
Yes, sure, sure.
Okay. So, in Graves' disease, we have these thyroid stimulating immunoglobulins that basically bind onto these thyroid receptors and then they start producing excess of T3 and T4.
Okay. Yeah, they
This
start
is
to
what I
basically,
remember.
they act like these TSHs and they depolarize and they cause this type of problem, right? That makes sense. That does make sense. So yes, that's one thing that happens. Okay. And that's why it's diffuse because it's taking up iodine all over the body and it's loading it up. So the radioactive iodine uptake is found. Now, in a situation of toxic adenoma, thank you for that. Thank you.
Okay.
In toxic adenoma, you have uptake of one particular part that's stealing everything, stealing all the iodine, and it's doing synthesis of T3, T4. So all these different situations that we're looking at here are having an increase in T3, T4. But look at how different it is, and you can tell a diagnosis with the radioactive scintigraphy that you're giving the patient. You can tell if it's a singular toxic adenoma because only one area, a localized area, is concentrated because it picked up all the radioactive type of iodine, it picked up the iodine, and it's basically doing synthesis. Then you see multinodular goiter. Here you have several types of several types of mass distributed around the thyroid. And that's what's happening here with this. So multinodular goiter. So this can really help to try to get your diagnosis, the scintigraphy. You can do it like that. And of course, it should match the symptoms. Symptoms should be fatigue, weight loss, palpitation, sweating, all these type of problems, insomnia. That's how you should approach in that sense. If I have a patient having all of this, I have to do a thyroid panel. I have to measure the TSH, the free T3, T4. And in Graves, let's see, Jessica, so you had your hand up before. Let me ask you one question.
Okay.
In Graves, how should I see the levels of, let's say, TSH?
They should be low.
Should be low, right?
Mm-hmm.
And when I'm looking at T3, T4, how should I see this?
They should be high.
It should be increased, right?
Mm-hmm.
All right, so that right there looks a lot like Graves. So next thing I would have to do is check for the features. What feature did we say was specifically a Graves kind of problem?
The pretibial mixed edema.
Yes, yes. But in this case, we don't specifically just need like the exophthalmos could be enough as well. Just any kind of Graves features. That would let us know, okay, it's Graves. That's all we need for the diagnosis. Graves features plus this type of thyroid panel with the symptoms of fatigue, sweating, palpitations, weight loss, tremors. That's the case, and we can just diagnose Graves right away. We can say, okay, the patient has Graves disease. Now,
Mm-hmm.
now, if there's zero features of Graves, which is crazy,
Yeah.
think about it, then you have to do something where you check the anti uh, uh, thyroid receptor antibody in order to see if the patient has it or not. So
Mm-hmm.
if they have that, that's it, they're diagnosed. So that's how you get your Graves, right? That's nice. But now here
Yeah.
comes the problem. What if they um, don't have any of that? And now you're like, okay, what's going on? This patient has hyperthyroidism. He's having weight loss, sweating, but he doesn't have the specific Graves features, which was like exophthalmos and pretibial.
Mm-hmm.
But at the same time, I want to know what's wrong. Next step here will have to be the scintigraphy. So in the scintigraphy, we're going to give this iodide 123 scintigraphy to see the uptake. So this is my question to you. What if all around I check and there's a decrease in uptake? Decrease in uptake.
Then it could be like a thyroiditis, where it was a transient increase in release of T3, T4, but now it's actually when you have inflammation, then it's actually gonna go low once it settles down.
Okay.
So
That
you check the R, right? It's called the RT3.
well, the RT3, this one here has that was for like sick euthyroid sick syndrome. That was like having a that's different. That's when you have a high lower level of thyroid. But so far everything you said was good. You mentioned that a decrease in uptake.
Mm-hmm.
That was perfect. Yeah, it can be a thyroiditis. It makes sense because if you have a leakage of T3, T4, right? T3, T4, that will give you the symptoms. So that will check you off with the symptoms that come with the increase in body temperature, weight loss, all that. You'll get the symptoms, but that will also not be Graves' disease as well. So that was a very good one. But I'm here stuck with between two diagnoses here because yes, you did say thyroiditis, which was great.
Yeah.
But remember that very commonly, there's issues where you can have um, Hashimoto's in the very beginning
Mm-hmm.
causing thyroiditis. So the first thing I should do if I see it's thyroiditis, because yeah, you did say it correctly there when you talked about thyroiditis. Thyroiditis. The other thing that you said, that you thyroid 6 syndrome, there your thyroid levels are going to have a problem. There, that's going to be a little bit different. There, your T3 is not even functioning correctly because of the RT3. But here, in this sense, thyroiditis, we have to think of the most common, which is Hashimoto's. We have to rule out Hashimoto's.
Mm.
That's like going to be the first thing. And how do you rule out Hashimoto's? You check for the antibodies. So
Mm-hmm.
the antibodies are
PO?
what was it?
Anti-TPO?
TPO. Good. And what's the other one?
Uh, I don't know. I know it's the 5'. I don't know.
All right, I'll tell you. I'll tell you. Hold on. So yeah, yes, Dr. Carey. Yes, I'll tell you why. If we remember in the very beginning of this whole class, the one thing that I emphasized on was the players of this game, the players
Mm-hmm.
of that play the role, and what the two of the major players. Remember, TG is one of them,
Mm-hmm.
and also uh, TPO. So
Mm-hmm.
in Hashimoto's, you can have autoantibodies that go against these two things. They can go against these two things.
Mm-hmm.
So we check for anti-TPO, we check for anti-TG. And if
Mm-hmm.
any of that is positive, we have our diagnosis is Hashimoto's at the early phase when there's that leakage that's going on. And then after that phase is going to get to a point where there's hypothyroidism because the
Okay.
functionality of the thyroid starts to drop. All right,
Mm.
let's say, so somebody said it can be a tumor as well. Well, let me tell you, if I try to do the uptake and I see that there is no uptake, decrease in uptake, then I shouldn't have hyperthyroidism. See what I'm trying to say? So for the tumor theory, it's going to be hard there for it to be a tumor because if I have a tumor, it should be trying to take up a lot of the iodide because it should try to take the precursors of T3 T4 in order to create more. So if I do it and there's a diffuse loss, then it can't really be a hyperfunctional type of tumor. Hopefully that makes sense. So okay, you're following me here. Thyroiditis. We checked for Hashimoto's, and boom, most likely it's a diagnosis because it's very common. Let's say it's not. Well, we are exhausting everything. It's not. So it's like, whoa, hold on. We have to wrap our head around this now. Because what I'm telling you is that so far, let's be clear. So far, I'm giving you a patient who has a decrease in TSH, right? I'm also giving you a patient who has an increase in T3, T4. He has the symptoms of a person who's hyperthyroidism, who has hyperthyroidism, but it's not Graves and it's not Hashimoto's. And we don't know if it can be another type of thyroiditis. So, yes, Dr. Carey, here, basically, we're stuck between these two things now. We don't know if this is, let's say, an issue with the core veins, thyroiditis, right? We don't
Mm.
understand if this is something where there's an inflammation because of some kind of viral infection or something. So we have to now check out the difference. We have to see the difference. So this is what we're going to do for this one. If the TSH here is low, T3, T4 is high, it's not Graves, right? Graves and X on it is not Hashimoto's.
Mm-hmm.
Leaves us with the idea that it can be two things. One thing is just a thyroiditis.
Mm-hmm.
So many different causes of thyroiditis. It could be viral, it could be the veins, top of my head.
Mm-hmm.
Or it can be exogenous. This person is literally buying thyroid from the internet in one of these websites because it heard that you can lose weight by taking a bunch of thyroid. And he's trying to, I don't know, take it to try to lose weight faster. So
Mm-hmm.
yeah, is ectopic production of TSH a thing? No, I'll tell you what it's not really a thing, but you do have TFL. I don't know if you remember that. That's the alpha subunits that are shared from different types of hormones. So remember, if you have an increase of any of these hormones, they do share some kind of molecular structure that's very similar. So in a higher level, they do have an increase in Km to the thyroid, meaning that their affinity is decreased to the thyroid gland. But if you are able to increase your FSH so high to a point where it's all the receptors of FSH are saturated, it can then find its way to TSH receptors and then bind because of the sharing of the alpha subunits. You guys remember
What,
that?
can you tell us what that is to the acronym?
TFL, beta, I remember it was beta HCG,
Mm-hmm.
TSH, FSH, and LH.
Okay.
They share the alpha subunits in that sense.
Mm-hmm.
It can then cause increase in T3, T4. Yes, that is correct, but it has to be so high that all the FSH receptors are saturated. They have reached Vmax. They reached the point of, if you guys remember that, don't want to confuse anybody, but just letting you know, like they reached the level of Vmax where they're like, okay, I'm maxed out. I'm full. So then these hormone structures that I just mentioned, they share that alpha. So they can then say, okay, well, where else can we bind? They're going to find receptors that allow this alpha subunit. So yeah, in cases like that, you can have this problem. But okay. So yeah, ectopic creation of TSH is not really there. But yes, we do have this crazy function with the similar alpha subunits. But okay, going back to exogenous. If there's one thing I can check now, one thing I can check to differentiate between these two things, which is awesome if you think about it. I do remember one player of this game, Jessica. There was one player of the game that was supposed to stay inside the thyroid. He was never supposed to leave. He was
Mm-hmm.
just supposed to do his job inside the thyroid. Doesn't have passport. He can't leave. He has to stay there in that place, concentrated. So
PPO?
it's not TPO because TPO is going to more be like an enzyme. I'm talking about a protein that can leave and then cause some kind of like marker. You almost got it though. You almost got it.
Not iodine, right?
Not iodine. Iodine travels around the body.
Not thyroglobulin?
Thyroglobulin. Thyroglobulin is
Oh,
supposed to stay inside the thyroid. So
oh, okay.
this is what will differentiate these two things. If it's thyroiditis, then I expect not only for T3, T4 to leave, you guys should also be dumping out TG.
Mm-hmm.
So TG in the serum should be increased. That'll let me know that it's an inflammatory problem of the thyroid. Now, if I check TG and it's low, that means that this is fake. There is no real leakage going on. Because
Mm-hmm.
how are you only leaking T3, T4 and not TG? TG is selectively saying, okay, you guys leave and I stay inside. That's not going to happen. TG should
Mm-hmm.
not have a choice. It should also leave with the T3, T4. So if it's exogenous, TG should be lower. Does that make sense? Does that?
Yeah. Yes, yes, it does.
If it doesn't, let me know because I could explain it.
No, it does. It does.
Okay. So I'm going to show you this little image right here. Boom. Check thyroid globulin. Thyroid globulin range 1.40. You don't have to remember that, but just know high, low. And hopefully that makes sense because if you're kicking things out of that thyroid, that should be
Mm-hmm.
part of the things you kick out. It should be TG. There's not selectively kicking things out.
So,
Everybody
so,
out.
so, so some thyroglobulin does leak out, even though it's not supposed to. So we do have a range in the serum. Okay,
Yes.
got it.
Yes. Good, 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 good.
Mhm.
So, all right. That's perfect. That's perfect. And yes, Miriam, you can have hyperthyroidism because of some kind of tumor that creates the same kind of Like for example, beta HCG. There's some tumors that can create high levels of beta HCG at super high levels, and then that type of HCG will start binding to the TSH receptors and then cause those type of problems. So you can have that problem. So yeah, but directly making TSH, yeah, that yeah, choriocarcinomas had high levels of beta HCG. Yes, if they supersede the levels of the receptors, you're going to see that they will now saturate other types of receptors that allow their affinity, allow them to bind. That's what you end up seeing. So yes, that is a problem. Um, so okay, perfect. So I think we know how to diagnose now, right? I think we have a good idea of
I
diagnosing
think
this,
so.
right?
Yeah.
It's not bad.
Mm-mm.
Let me ask you then, what if I have a patient who has a increase in TSH, increase in T3, T4? What am I thinking? What could that be?
Then it's like central.
Okay, so what's the next step in management there?
Then you could do maybe an MRI of the hypothalamus area.
The
And
pituitary MRI. That's perfect.
yeah.
TSH because of the pituitary. Definitely.
Mm-hmm.
Perfect. That makes a lot of sense. That's good.
Yeah.
So okay, I think we have it down when it comes to diagnosing, and that's great because yeah, we jump into questions. We're going to see all these different types of features, and they should now all make sense. The only thing left, I think, was just the histological descriptions. Well, no, I think all this makes sense. Um, there's small clues that have to be there. So when we do finish these subjects, it'll be nice to have a drill where we just say all these buzzwords, we get them out the system. Cancers, I'm not going to get into on this cycle of endocrine, just because the cancers, you'll see that when we do oncology, we'll be able to go from system to system and get the cancers well understood. So, okay, hopefully everybody understands this. Hopefully this makes sense to everyone. If that's the case, um, definitely let's end it now. We have about 2 hours, and tomorrow we could continue. And yeah, we have a question session tomorrow as well. So we'll implement questions that we have for this. And hopefully, yeah, I looked for some questions. I did find some hard ones. There's a couple of them. So make sure you know what we talked about today, especially when it comes to pregnancy and the fluctuation of levels of thyroid hormones, especially when it comes to the euthyroid 6 syndrome, all that. What time? So let's see the calendar. I put it for 4 o'clock, the question session, and I put the class. So let me put the calendar on the screen. Take a closer
Is that
look.
for everyone or just for the other Patreon?
No, that's for the other Patreon when we do questions,
Oh,
but I'm still gonna have the class as well for everyone because I'm gonna give double class tomorrow. I'm gonna try that out.
same time, 8 p.m.
8 p.m. Yeah.
Okay.
So yeah, this is what we have for tomorrow. Tomorrow's Friday. We have 4 p.m. question session where we
Mm-hmm.
look at questions of everything that we did today, and then 8 p.m. we basically finish endocrinology. We're gonna finish up endocrinology.
Okay.
Definitely, I'm gonna upload this video tonight and Saturday. Hopefully everybody can make it. 4 p.m. We're gonna have another question session just to make sure we finish all of that, and then we'll have a drill. This drill should be endocrinology drill, a drill based on all these features.
And
4
all the
p.m.
drills are
Yeah,
anyone can go, right?
all drills are free. Tell your friends, tell anybody. We'll be doing drills. The more students, the better. Everybody can start responding. I can start asking other questions, more engagement.
Mm-hmm.
Definitely. Yeah, we have 4 p.m. Saturday question session. If anything, if can't make it, I'll definitely upload it. Definitely on the page. And yeah, I'm trying to get a good time for the question session. I don't know exactly what time benefits everyone. I could move it around, so I'll see. I'll see what happens with that. But this is definitely the calendar we're going to stick to. Oncology, yeah, oncology is going to be a crazy subject, but we'll give that. We'll make sense of it. And then yeah, that's basically what we got lined up for this month. I do want to give an extra drill though. I want to see if I can give some more drills. We'll see what happens. We'll see if some space frees up. But definitely, thank you everybody for joining me. And I will upload the video definitely tonight, and I'll catch everyone tomorrow. All right.
Thank
Take
you
care.
so much.
Thank you. Thank you everybody for joining me. Definitely. All right. So have a good night.